Good afternoon, everybody, and thank you for coming. Historically, the treatment of patients with metastatic solid tumors has been based on systemic therapies that aim to delay progression and extend life, but not to eradicate the disease completely. The oligometastatic paradigm, formally named in the 1990s, but anecdotally reported as early as the 1930s, suggests that patients with a limited number of metastases should be amenable to a curative treatment approach. But randomized data are lacking. To our knowledge, the oligometastatic paradigm has not been directly tested before in a randomized trial. Specifically, there are no completed RCTs with a primary endpoint comparing overall survival between any ablative approach, whether it's surgery or SABR, versus a palliative approach in patients with oligometastases. And it might surprise you, but some clinical scenarios without randomized data include the surgical resection of lung and liver metastases from colorectal cancer and SABR for oligometastases at any primary site. The purpose of SABR-COMET was to assess the impact of SABR on overall survival, oncologic outcomes, toxicity, and quality of life in patients with up to 5 metastatic cancer lesions and a controlled primary tumor compared to standard of care treatment alone. This is the study schema. Patients with up to 5 metastatic lesions were randomized in a 1:2 ratio between standard of care, palliative radiation, or systemic therapy at the discretion of the treated physicians, or SABR, followed by standard of care. Crossover was not allowed as part of the protocol. The primary endpoint was overall survival, and secondary endpoints included PFS, toxicity, quality of life, lesional control rate, and the number of cycles of further systemic therapy. As the trial went on, what we found with this latter endpoint is that patients near the end of life preferred to have systemic therapy near close to home. So we changed this to a binary variable, receipt of systemic therapy, yes or no. The main inclusion criteria were a controlled primary tumor, defined as at least 3 months since the original tumor was treated definitively, with no progression. You could have up to 5 hematogenious metastases, up to 3 in any single organ, and all had to be safely treatable. Main exclusion criteria were serious medical comorbidities, prior radiation to a site requiring treatment, malignant pleural effusion, or tumor close to the spinal cord. We used a randomized phase 2 screening design, which I'm going to go into briefly, and you can read more about in this paper. For a standard phase 3 trial, we set the hurdle at an alpha of 0.05. If your p-value is below this, then your trial is positive and definitive. For a randomized phase 2 screening design, we lower the hurdle slightly with an alpha of 0.2. If your p-value is below this, your trial is positive, but not definitive. It's meant to provide a moderate sample size for an initial non-definitive comparison between 2 arms. But once the trial is complete, a finding can be considered definitive if the p-value is less than 0.005, and I will come back to that a bit later. The SABR details are shown here very quickly. I'll show you at the end where you can find the protocol, but the number of fractions were dependent on the tumor size and location. But the important thing is that normal tissue tolerances were not to be exceeded, and the PTV coverage was to be compromised wherever needed. We estimated a median survival of 9 months in the control arm. To detect a 6-month improvement in OS with 80% power, a 2-sided alpha of 0.2, and a 5% dropout, 99 patients were needed. All analyses were intention to treat and pre-specified, unless I let you know otherwise, and we assumed 4 years of accrual and 1 year of additional follow-up. The data set was locked as of January 2018. Between February 2012 and August 2016, 99 patients were randomized at centers in Scotland, Canada, Netherlands, and Australia. The baseline characteristics are shown here. The median age was 68, most were male, and there was a fairly even split among breast, colorectal, lung, and prostate patients. There were no significant differences between the groups at baseline, but I want to point out that the majority of prostate patients were in the SABR arm. I will come back to that later. Most patients had 1, 2, or 3 metastases, and as a result, we feel that these results apply most to that group. I will point out that all the patients with 5 metastases were in the SABR arm. Most of the metastases were in the lung or in the bone. For the primary endpoint of overall survival, the Kaplan-Meier curves are shown here. The SABR arm is in blue and the control arm is in red. The median overall survival was improved from 28 months to 41 months with a p-value of 0.09, meeting the primary endpoint of this trial. The 5-year survival, or 4 years and beyond, 24% in the control arm and 46% in the SABR arm. For PFS, the curves are here. The median PFS was doubled from 6 months to 12 months. The beyond 4-year PFS in the control arm was 0, and in the SABR arm was 16%. I want to point out that that PFS in the SABR arm is an underestimation of the number of patients who are alive without disease, because 8 patients who progressed on the SABR arm received salvage SABR after they had progressed. In terms of adverse events, those are shown here. These are related events as determined by the treating investigator as possibly, probably, or definitely related. You will notice about 29% grade 2 or higher toxicity in the SABR arm, 9% in the control arm. There were 3 deaths that were thought to be either possibly, probably, or definitely related. Because of time, I can't describe those now, but those are in the manuscript. Additional secondary endpoints, SABR was not associated with a decline in quality of life.